KK and the rest of the panelists here, thank you for staying behind until the last session. I have with me Jonathan Yap, one of our up-and-coming interventional cardiologists, and also Sister Tina. Very fortunate to be able to have her here with me today. So we have an interesting case for you to showcase how we can reduce the amount of contrast for patients who have CKD. So without further ado, maybe I ask Jonathan to present the case.
Yeah, so good morning. It's my pleasure today to give you a brief introduction to the last case of SingLife 2024. And so we have with us here a 78-year-old gentleman. He's got the full house risk factors of diabetes, hyperlipidemia, and hypertension. And he's got CKD 3. Next slide. With regards to his coronary artery disease, he's had a significant history of a PCI, both to the LAD and RCA with bare metal stents in 2009. And at the point of time, his ejection fraction was normal. He came in just a couple of weeks ago with some unstable angina, and when we repeated his echo, his ejection fraction was about 48%. And the coronary angiogram, which we will go through later, showed a double vessel disease with left main involvement. We actually DCB'd the ISR about a week back. Next slide. And these are his lab results. His creatinine this round on admission is about 136 micromoles per liter. Hemoglobin is normal. Next slide. So this is just a quick shot to show the ISR in the RCA that we did a DCB to. And so that's the after result on the right. Next slide. And just to give you a flavor of what we are dealing with today, and we'll go through this in detail later. As you can see in the distal left main, there's an extremely tight lesion, about 90–95%, and this extends all the way from the distal left main all the way to the mid-LAD, so very diffuse tight stenotic lesions all across. Next slide, please. So that's just some more pictures of what we're going to tackle today. Next. So this is the risk assessment for the patient. His Maran risk score is about 9, so that gives a risk of about 14 to 15% of some kidney injury and about 0.1% risk of dialysis. His syntax score is about 34. Next. So today, just to summarize, we have a patient with a left main double vessel disease, also has CKD, and we hope to showcase some of the techniques to help to reduce contrast load and at the same time achieve good PCI outcomes.
Thank you, Jonathan. So actually, this patient, as Jonathan has mentioned, did a DCB to the right about a week ago. The contrast use was actually not very much, about 30 ml, and his creatinine actually shot up from about 120 to 135 or 139. Around there. So, but he has some hydration, and then I think yesterday is like 125, 129, around that level. So it's important for us to try to reduce the contrast load as far as possible for patients who have CKD. So we are going to show you the angiogram today. This one actually was done previously when he first came in. So this is a diagnostic angio. Not done today. This is the original angio when he first came in. You can see the very tight distal left main. Circ doesn't seem to be involved. The ostium of circ doesn't seem to be involved. Also, there's an in-stent restenosis in the proximal LAD. I think it's a 3O stent. And then the mid-LAD also has quite significant disease. I can show you here in the areocrania. So diffuse disease, fortunately not so calcified on angiography. And then I think that's all I have here. So maybe Jonathan, you want to go ahead and tell us what you did so far?
Okay, so I'm just good. So of course one way to save contrast is to merge some of the angiogram images from the previous PCI. So that's exactly what we did here, so that we can have a roadmap above. So far today, up to where we are, we have not used any contrast. We use ultrasound-guided puncture on the right femoral artery. He has a right radial loop, so that was tough to go across previously during the intervention, so we decided not to go from there. And we marked the point of entry of the needle into the femoral head. As you can see here, we are mid-femoral head. And when we engage the coronary, one of the techniques is to have a wire to stand by so that you don't have to test to make sure that you're in the coronary, and you can kind of push your wire, and if you see it going to the coronary artery, you know that you're kind of there. Next, this is some of the wiring. We had the roadmap of the previous NGO.
So maybe, Jonathan, before we go into that, maybe we can let KK and the panel tell us what they would consider will be the right approach for this patient.
Yeah, thanks very much, Prof. Koh and Jonathan, for sharing this case. I'm Hiwa here. Just want to ask, because I understand that you are using the Philips system, so one of the considerations would to use the roadmap to do the wiring, you superimpose the image. And of course, we're going to ask our Stella panels what they're going to do in terms of reducing the risk of CIN for this patient. So I think if you aim for ultra low contrast PCI, you will go by, you will limit your volume of contrast according to the EGFR, means that in your case it will be 50 mils or less.
Very good, yeah.
Yeah. So maybe I'll ask Alan, what would you do in Hong Kong?
Yes. Thank you, Alan from Hong Kong. Thank you, Professor Koh, for the invitation again.
Yeah.
So I think yesterday we have a lecture, I think the whole section talking about the ultra-low dose. The key question, first of all, I want to ask is what is the pre-procedure planning for this patient? I mean, in particularly hydration protocol for this patient. For us in Hong Kong, for these kinds of CKD patients, of course, we hydrate them, but on the day of procedure, while we're doing before the first engagement, we usually try to further assess the filling pressure by means of a LVEDP. We just give a quick diagnostic catheter, cross the aortic valve, and then measure quick EDP. Out of the surprise, even for those high-risk patients in parallel support PCI, we found half of our patients will be actually, their filling pressure is not high. Even the EF is 20. CKD 400, for creating 400. Out of surprise, some patients will get low EDP. So you need to give fluid, particularly for long procedure. I think this is a challenging left wing bifurcation lesion, so you need a lot of further wiring, assessment, and then ballooning. So adequate hydration is the key to, apart from minimizing the contrast.
Yes, I agree that, yeah. I think we gave some hydration overnight. And then normally in the lab here, we would continue the IV hydration because the ejection fraction is pretty okay, 48%, not so bad. So that gives us some room to hydrate. Normally, we would at least run 1 pint of fluids fast. If the creatinine is really bad, 200-300, then some of my colleagues have done that, your protocol, as you mentioned. We have a protocol for renal protection as well here. Yeah, so any other contributions from the panel?
Maybe you can ask Dr. Shani Pereira, what would you do if you face a patient at risk of CIN? What's your practice in Sri Lanka?
Thank you. So I'm Tanya Pereira from Sri Lanka. Yes, we frequently face this question because we have a fairly high degree of chronic renal disease, especially in some parts of the country. So I think what we are currently actually practicing is that we also have the Philips machine. So we are actually using the roadmap to, we keep these patients well hydrated and we get an FLOG opinion, and we keep the roadmap, and actually we using minimal amount of contrast by using the roadmap for wiring. Unfortunately, we are not having, all our cath labs are not equipped with intravascular imaging. So we have not been able to go in for zero contrast, but we have been minimizing it actually with the roadmap now with the Philips.
Thank you very much. I think we also face the same situation. We have one lab wired or installed with the dynamic roadmap, but unfortunately in this biplane room, we do not have that at present. But I think we can make do. I think that's not the crucial thing for now. So because of interest of time, maybe I ask Jonathan to go ahead to tell us what he has done so far.
So we have actually wired the LAD first. So our decision was actually to protect the LAD, the circumflex, as well as one of the bigger diagonals. So this is some of the wiring done with NGO roadmap on the top of our screens. So that, yeah, this is the wiring of the circumflex, the quarter view.
So it's a 7 French guy, EBU 3, right? 3.5? 3.5.
3.5.
Okay, yeah.
And this is the wiring of the one of the larger diagonals that we thought we would protect and just provisionally.
What are your wires?
So I have a Xion in the diagonal. I have a run through in the LED as well as a Xion blue in the circumflex. And if you all know the color of the Xion, will help us differentiate from that of the Xion blue as well as the run through. And in particular for the run through, you know that the edge, the back end of the run through is jagged, so you can differentiate that from the Xion blue. So all 3 wires are quite differentiatable. So that kind of helps us. So because the left main was really tight, and we decided that we would need to at least open up a little bit of the lesion before we did some intravascular imaging. And this is just a 2O balloon going up from the mid LAD all the way back to the left main. As you can see here, you know, when we're inflating the 2O balloon across the left main, the balloon kept slipping. So this happened a couple of times. We didn't try too much longer. We thought that the IVUS may occlude flow a little bit, so we went up with a 2.5 NC score flex.
There is some residual waste, isn't it?
Yes, with the 2O, yes. So before we put the IVUS in, we thought we would just prepare the lesion a little bit more so that there's a little bit more room for blood flow. So we went up with a 2.5 NC score flex. This is the 2.5 going up, and you can see here, this is the 2.5 NC in the distal left main. Still a little bit of a waste, but I think enough for us to put down the IVUS guiding catheter for us to get further information on, you know, how to plan our strategy. So this is the IVUS. Maybe we can show the IVUS images. Maybe run 1. So this is the IVUS of the LAD. This is from somewhere mid to distal LAD. You can see it's about the 2.5 vessel, and now it's coming to the mid diffuse segment of disease in the moment.
It would be great if we can have like angio core registration with the IVUS, so it's coming in future, pretty near future, with a high definition as well. So that would be good. But right now we don't have that.
Yep. I think the other IVUS system that have co-reg is the Philips IVUS co-reg.
Yeah, but it's only at 20 megahertz, so you know the imaging is not as clear as what we can see on the other 60 megahertz IVUS.
Alan, you have a comment?
Yes, I think nowadays we have so many branches of IVUS, but not all have co-registration. So actually we developed some kinds of strategy to use so-called the minimal contrast IVUS guided, the PCI. So I think some of the key points is, first of all, try to use the best angle. For example, you are doing LAD, you are going for a RAO or AP cranial, and then fix that. Ask your fellows or the radiographer, don't pan the angle anymore. You best get the best angle, and then while you are pulling back your IVUS, when you have your certain landmark, for example, distal reference, proximal reference, then you get a cine, and then that is your reference. And then you compare pre and post while you're doing further ballooning or stenting. Then this is more or less like a homemade co-registration by your own. Then any kinds of IVUS you can do it by yourself.
Yeah, so maybe you want to show the homemade co-registration.
Yeah, so we found a little point on the mid to distal LED that we thought was a good landing point for the stent, and this is a cine of so IVUS.
Okay, they see.
Yeah, we kind of IVUS marked it at this spot in the LED, and we measured the distance of this area to the. If you all have noticed on the IVUS as well as on the angio, you can see the stent edge of the previous bare metal stent. So from this point all the way to the bare metal stent is about 24 millimeters long. So after we did the LAD, we've proceeded to IVUS the circumflex. So of course we are thinking of more, the ostium of the circumflex, at least angiographically, looks pretty all right. We're thinking of a more provisional strategy to keep this already fairly complicated procedure simple, and so we don't have to expand too much contrast. Can we show the IVUS of the circumflex?
Great narration, Jonathan. The other thing is that we can use the side branch wires as landmarks also to guide your length as well. Yeah, your diagonal wire and the branch off from the circumflex. These are all useful landmarks to guide.
Yeah, it's called a metal tree. But because we got 3 wires in, you know, we have to put another 4th wire into one of the lower diagonals to achieve that. So we thought cheap IVERS marking will be
We are
reasonable.
coming to the ostium right now, so you can see the ostium looks fairly all right. I'm not sure if everyone caught that. There's an area of borderline lesion somewhere after the high OM, somewhere in the mid circ, but you know, I think we're going to elect to leave that alone for today.
There is a lesion in the mid of the left main, but on IVERS actually just an outpouching. It's not really anything serious, so we're going to not do anything to it, but probably stand it.
I think we noticed that there was an area of waste in the balloon, so I guess there's no presence of calcified nodule in that area.
No, it's just I think 1 or 2 quadrant and the most calcification. So because of that, we went ahead with the higher pressure balloon. Jonathan, you want to show that? Yeah. Or bigger size rather, and.
So I noticed, Jonathan, so far it's quite interesting that you have not injected any contrast. So yes. At what point will you inject contrast? I mean, at the end of the procedure, or?
We may use some contrast when we are going to place the stents, you know, but we'll see how confident we are about the position. I think right now, you know, with IVERS sizing, you know, we are pretty confident that we have not gone up too big to perforate the artery or anything. So, you know, we haven't felt the strong need to check, at least at the moment. We went up again with the 2.5 NC score flex just for the mid to distal portion. And because we have a good sizing on the IVERS, you know, the left main and the at least the proximal LAD was sized about a 3.5, so we went up with a 3.5. Sorry, is this the one? Yeah.
Aperture.
Yeah, this is a 3.5 scoring aperture. So for those of you all who know the aperture, the score flex has kind of 1 scoring element, and for the aperture, you know, they have like 3 different scoring elements, and can go up to a pressure of all the way up to 24. So a pretty good scoring balloon. So this is the aperture and the distal left main to proximal LAD. And you can see the waist is much better than before with the smaller 2.5 NC score flex. And we dilated all the way from the distal end of the bare metal stent that was previously put with this 3.5 NC balloon. And so that is currently where we are at the moment. We did the final IVERS run, but I think in the interest of time, you know, it doesn't show too much more, so I don't think we have to show it. So right now we are actually planning to put our first stent in this mid-LAD portion.
I think we are quite fortunate in this case that we have a stent already implanted, so you can use the stent as a marker as well. Yeah.
Looking good so far.
Yeah.
Please carry on, and then we can discuss further.
Yeah.
Maybe we can ask Ronald, would you like to do an angiogram before you put in the stent at this stage, or you still...
2528. 2528.
I think I probably would do an angiogram. Okay. At least so far, he has not given any contrast. At this point in time, we still have around 50.
No, 29, 2529 should be all right.
Yeah.
I just want to ask a question. And do you think the guide extension will help to facilitate this stent placement, given the age of the patient and the diffuse disease nature of the LAD?
Yep, so there's a question regarding whether we should use a guide extension catheter. Ronald, good question. Aisha, what do you think?
I think given that there was some waste, it might be of some use, but I'm just concerned about the fact that we have roadmaps with the wires and the stent in place, and I just wonder to what effect taking a guide extension down might distort that roadmap we have in place, so that we don't need to inject contrast. And regarding the contrast issue also, I probably won't inject now, but maybe when taking the stent down, just before placing it, during the process of taking it down, that might be a good time to inject contrast.
You're holding the other one.
Dr. Edu, any thoughts on whether a guide extension catheter might help with saving on contrast?
I think the guide extension catheter can help, but in this case, because you've got left main with a bifurcation in the circ, there's a limit to how much the guide extension can go in. So it cannot cross the circ.
There's stent boost here.
So probably not much value in that situation. And given that they actually don't use contrast for most of this procedure, and probably don't need except for the final shot.
I think we go down a bit because
You
there's
may
a
not need
question
unless
there.
you need more support to deliver your devices.
Thanks,
Go right
Dr.
to
Yu.
this, come back.
Prof. Ko, can I
Yeah,
check what stand is
Sydney.
that, please?
Okay, so this one is a Bio Freedom Ultra 2.5 by 29.
2.5, okay,
Yeah.
great.
So, so you can see that we are using the stand boost to help us precisely position the stand without any need for contrast. That's why I said the stand, the previous stand is a great help for us in this case. So I think we are quite okay to go ahead to start the deployment. If you guys are all right.
I just have a question about the choice of stent. Could you elaborate on why you chose a BioFreedom? We noticed you had calculated a precise DAP score of over 35. Is it related to post-PCI DAPT?
Not quite so in this case. I think it's just one of those stents that we can use. Yeah. Of course, if you have a very high bleeding risk, then it will be very helpful. Yeah. What sort of stents would you think that would be best in this kind of CKD situation?
Aisha, you, yeah.
I'm not quite sure if there's a preference per se. I mean, the stent I would choose would be guided by post-PCI DAPT, and this patient is presumably at some degree of high bleeding risk. So, yes, I think this is a good choice.
Yeah, thank you.
I guess many of the modern stents have data for short duration DAPT use, and I think in this particular case with the multiple comorbidities, as it turns out, many of the risk factors for high bleeding risk are the same as for ischemic risk, so it's a bit of a balance, but fortunately nowadays we do have a variety of available technologies.
So we have already deployed the first stand. So what do you all suggest, the panel?
Yeah, I think
what should we do?
So, Prof. Ko, there is a stand, prior stand in the prox LED.
It's a BMS, yeah.
So it's a bare metal ISR. So it's either you have to see the angiographic result after your POBA. If it is good, maybe you can consider drug-coated balloon. But that will require contrast. And of course, the other option is to stand. So we'll be interested to see what are your choices.
Yeah, I mean, fortunately, we have IVUS, so the IVUS can really help us guide whether the lesions are well expanded and there's any significant plaque prolapse that require stenting. So we haven't shown you the IVUS, right? So
we can replay the IVUS again.
After we
balloon.
After, no.
Yeah. We show the last IVUS of the LED.
Okay, so we'll show you the last IVUS after we balloon. So the IVUS is a great help.
So this is the mid. So this is the mid segment that we just stented. No.
Before we didn't have IVUS after the stent.
Yeah.
So there's some
before the stent. So this area of fibrotic lesions are the ones that we just stented, and we should be coming to the stent edge in about 10 more millimeters or so. So this is the distal stent edge of the bare metal stent. You can see at least up to the point of entry of the diagonal. You can see the diagonal wire coming in. The stent is actually fairly okay. But proximal to the stent edge, there's a little bit of ISR, and you can see that little flap coming at about 12 o'clock.
I've never been terribly confident for left main DCBs, no matter what IVUS and angio show. So, but I think in this case you have illustrated very well the power of intravascular imaging to be able to delineate the underlying anatomy and hopefully guide whether we can use the DCB. But I'm going to ask Hee Hua. Hee Hua, you are a well-known expert in using DCBs. Would you, having seen this particular IVUS, put in a DCB or?
No, it's just a stand in the LED ISR. So I think if
there's the left main, that flap there.
No, that one has to be covered with a stent. Yeah. I think for safety reason, you have to do it stented.
I think there's pretty much broad agreement, Prof. Ko and John, that in the setting of that, that flap that you showed, we probably would prefer to put a stent. What are you planning to do?
So we're going to DCB the in-stent restenosis because there's also a diagonal there as well. So and then we will implant a stent to cover from the ostium of the left main into the proximal LAD. So that's our strategy. Then at the end we will DCB the middle portion.
Okay, that
I think it's a reasonable approach here.
Yeah, I think that's what everybody is nodding their heads to. So, and what sequence will you do? Will you put the stent first or you DCB first?
So in our mind, we thought it's better to implant the left main stent into the LAD, and then because you also because it's a professional stenting, we need to manage the circumflex as well first, and then at the end, everything goes well, then we would DCB the mid portion. If it's still needed, we can still overlap another stent between the two stents.
Yeah, and I guess the other reason is because you would worry a little bit about the residual disease in the left main getting in the way of a slightly more bulky drug-coated balloon.
Yeah, it's a good consideration, but I think the dilatation is quite good. Yeah. I'm not sure whether you saw the IVUS of the left main. You can see the outpouching, quite an interesting kind of phenomenon. Can you go back all the way to the left main, start of the left main, pull back all the way, some more, all the way. Stop here. Okay, play. It's just a very momentary image. It's at around 12 o'clock. Can you see here?
Yeah.
Yeah. So that's where this sort of like a napkin ring kind of picture you saw on the diagnostic angio.
Can we go to L cranial?
So the left main to LED stand is going to be a biofreedom as well, Prof. Ko?
Yes.
I think they have a good expansion range, so I think it's a suitable yes.
Yeah.
Maybe at this point we should do a little bit of a test, huh? To see where the ostium of the
Yeah, we need this one. We definitely need some tests. I think there are a few options that we can do to inject contrast. One, of course, is to use a guide extension catheter, but we've got a couple of wires there. Another option is to inject just directly, and third option is to use a thrombuster, which I've used sometimes to inject dye. But this one, because the amount of contrast we can use is around 50, so I think it's okay for us to just check. And the left main is crucial implant, so we should do a test injection. Huh?
Okay.
Yeah. Fill the catheter first so that we don't use too much contrast.
Alan, when it comes to ostial left main stenting, would you consider putting an anchor wire to guide what we call a sapper wire technique?
Right. It depends on where you're going to land your proximal stent. Right. We really go to the real ostium, probably. Usually, I just put a wire in the cups. Just facilitate, first of all, to prevent your guiding going in, make your standing more easy, and then you also delineate your exact position. Of course, I think nowadays so-called sabo is a little bit out of favor. We're still doing a little bit, but not many. But, anyway, I think that there's lots of tips and tricks to precisely place the ostial standing.
But this one, you're not going to land at the ostium, right? So
yeah, so you need some contrast, you see.
Yeah.
Or on the other hand, because you're using IFAS, so you already have a marking in the proximal LAD. So actually you can, you are not judging from the proximal, but try to use the exact length, because nowadays you have so many kinds of stent with various length, starting from 15, 16, 18 to 20. So I think, or even a little bit longer. So it depends on how many to overlap, and then depends on your IFAS length, and then try to choose the right size, and then judging the overlapping segment, then you should just focus on the overlapping region, and then it should be okay.
Do you think it's time to remove the diagonal wire?
So there's a question, Prof. Ko and John, Ronald is asking whether you should pull a diagonal wire.
Because we are actually implanting the same proximal or diagonal wire, we think it should be okay. The vessel is not very calcified, so there should be, we need to check first. Yeah, should be all right for us to remove it later if need be. Obviously, we need the IVUS first. Stop. Yeah, no.
It's a 7 French EBU
Stop.
guide.
Yeah,
Prof, what's the dimension of the stent actually?
We put the 3529 biofreedom.
And this is EBU guide?
This is the EBU 35 guide. We are just going to quickly post-dilate the ostium of the left main a little bit first, and then just give me a moment.
Enough. Let's dilate.
Okay, let's go.
Yeah. Okay, let's dilate. 12, 14, 16. Yeah, go. This is at 16 atmospheres. Okay, deflate.
35 NC?
Yeah.
No.
It's just the stand balloon.
Oh, the stand balloon. Okay.
Down.
Guide out, pull out the guider.
So we are disengaging our guider as we remove the balloon, so because right now we have a couple of trap wires, we don't really want to constantina the stents.
Excellent.
Yeah, the constantina effect is very unpleasant to manage. So how much contrast did you use so far? 2 puffs I saw, is it 3?
We took 2 shots.
Yeah. I think we only use a 5 cc syringe, so maybe like 1.5 puffs. And then I think very important is that at the end of the injection, you should try to remove the remaining contrast in the guider, which can be quite substantial, so which I have done. But while we are removing it, you've got to be very careful that you don't suck air in because you got multiple wires, multiple balloons inside. So that's the current situation. So we're going to IVUS again, I guess. Yeah, that's IVUS. To see how the deployment is, and in particular whether the ostium or the diagonal is affected or not.
I've got a question for maybe John and Prof. Ko or anyone from the panelists. Were you in this period of time do a port on the left main first? You say a 4-5 since the sizing is 4-5. Just in case if you lose wire, then you don't go under the strut.
Yeah, we should definitely do that. We just thought we would quickly put in the IVUS and make sure everything seems quite all right. And then next up, we are going to start dilating the 2 newly implanted stents.
It's a good tip that we should port it. But because we got 3 wires there, I think we need to at least remove 1 wire. Yeah. Hopefully the diagonal will be okay on IVUS at the ostium.
See my distal wire?
The wire. Okay.
It's getting a little bit cramped in the guide, with everything, so it's a little bit more sticky. So now we are in the mid to distal LED. We're going to start the pullback.
Okay, we're going to start.
See.
Maybe y'all can jump in. You want to interpret this one? Okay, so it looks like quite good. Yeah. Go
so
ahead.
This is post-stenting, no post-dilatation, I think. So the distance actually looks okay, but here I think maybe we can go up a little bit more. Perhaps even a 3.0 here, a little bit slightly under. But I think we haven't done a post-dilatation yet.
Yeah.
So it's pretty well opposed, good sizing. We should see the overlap part subsequently.
Yeah, this is the overlap, I think. Yeah.
Then we can get some clues whether we can do a DCB here. I think potentially can. And that's the diagonal wire coming through at 5 o'clock.
So we need to go back to see the ostium now. We will do a manual check and see.
You don't the ostium of the circ, you mean?
Diagonal as well.
Yeah. Circ, because we only use a 3.5, it might not be.
So this is the left main stand read. You can see the 2 wires that's drilled underneath struts. I think it's now coming out through. left main, or there's some malposition here. So I think it illustrates that. I think what Dr. Idu mentioned, probably also, at some point in time, it's good to do a port, initial port. Yeah.
Very good. So you want to go back to look at the diagonal? Yeah. Can go?
No, cannot. Take it out first. So we are able to resheath the IVUS. So we are going to do it back in the guide and then we bring it in again. As you know now, our guide can't sit into the left main because of the two.
Okay, so around there.
Yeah. So let's go manual. So now we are in the, let's see, we are in the distal edge of the previous bare metal stent. So I'm going back to where the origin of the diagonal is. And it looks kind of patent here still, at least on IVUS, at least the first 1-2 millimeters.
Yeah, it looks quite okay, you know. So I think
see the wire at 4 o'clock.
Yeah, it looks okay.
So with IVUS, it's really great help for low contrast PCI.
So I think you described also your concerns about the guide and interactions with the left main stent. I think, could you talk a bit more about that? What are you worried about?
In terms of, because now you implant, luckily for us, maybe we didn't implant directly at the ostium, maybe just slightly in, so not so as high a risk. But if you're right at the ostium, then your guide might be sucked in while you're removing your guide wires, those trap wires, and that can concertina the proximal stents. Actually, some stents are not so strong radial force, so that might happen. And then other thing, as I think one of the doctors have mentioned, that you need to port it, because otherwise, if you should lose your wires, could be a disaster trying to get in. It's not so easy in the big left main to cross the left main stand again if it's not fully opposed to the wall.
Should we remove this diagonal wire?
Yes, I think we should. You got to pull out all the.
So we're going to remove the diagonal wire, and once again, we're just going to disengage our guide a little bit, so that when we pull back this wire.
Yeah, I think that's a really important step. I think all of us
show us the guidance.
Have had the pleasure of dealing with concertinas and left main. Usually makes for another an hour or so of work.
Yeah.
Okay, so that's the diagonal wire coming up. We're just going to take it out.
One way to prevent that, of course, as you all mentioned earlier, is to put another wire outside the left main, right, into the aortic cast. Then that will prevent it from getting in to the ostium. But because we have so many wires, and then in the interest of time, probably.
So your next step, Prof. Koh and John, you're going to do the port of the left main stand?
So go ahead, Jonathan.
Yeah, we're kind of just going to post-dilate everything, including the left main stand with the port.
Can we see the distal? We're having a bit of ectopic, so I'm not sure whether the wire is in one of these side branches. Let's pull back a bit. Otherwise, ectopics. Maybe it's just his intrinsic ectopics.
What is that balloon?
It's a trio NC.
Okay.
That's stem boost. That's frontal.
I think you're a bit out, but we can stem boost first. Thank you.
Just low pressure here, 8.
I think one of the advice that from the ultra low contrast PCI experts, what they say is that, of course, we all aim for low contrast, but whenever the patients have chest pain, have hemodynamic instability or any arrhythmia, then we should inject contrast to find out what is going on, because at the end of the day, the patient safety is very important.
Yeah, definitely. I think patient safety overrides everything, even if you need to use more contrast.
But it looks like the rhythm has stabilized. I don't see any more funny looking beats.
Yeah, it could be the distal end of the run-through wire. Even though it looks not too deep, it could be in a tiny branch.
So right now, I mean, I don't know whether Dr. Pereira or any of our other panelists have any other additional tips and tricks on, or is this just going to be, more post-dilatation? Anything else you would recommend at this point in time?
Do I not that much?
22.
Yeah.
Do the
Maybe
post
you do a
dilatation
3-5.
I might also inject some
4-5
contrast to see whether the distal vessel looks all right. Because there are some tiny sections that we may be able to
Yeah,
miss
3-5
on
and see.
intravascular
Or
ultrasound.
dilate all first.
So just post-dilatation for now.
Okay, never mind.
It's only
Cannot
275,
worry.
quite small.
So what about the circ wire? You don't want to remove it yet, or just want to wait still?
Oh yeah, we want.
We will pot first, and then I'm not sure you can use our other wire that we pulled out to rewire, and then we can remove the circ wire after.
Sometimes the trap wire is actually our friend because it stabilizes the guider. So sometimes what we do in PCI is we do all the post-dilatation and then remove it carefully, because of course we think that it's a barrier, but sometimes it's actually your friend because it stabilizes the system. Yeah.
That's a good point. For the circumflex wires, I'm a little bit less worried about trapping it because the distance under the stent is usually not so much. But in the case of the diagonal, we have a quite long length of the LED stent by which it's trapped. So we thought it would be safer to remove that wire before we post-dilate.
So this next question is, because I don't use the Sion or the Sion Blue that much, how sticky are they, and will they be easily trapped? I mean, I know we have had run-throughs trapped, we have had BMWs trapped, but how likely is it for the Sion and Sion Blues? This is a Sion Blue, right? Or is it a Sion?
The Sion was in the diagonal, you're right. So we kind of put the Sion out. The Sion is a hydrophilic wire. I think it's a bit less likely to get trapped. So it's kind of a good wire to protect your branches.
Yeah, I think that's a good sort of learning point, I guess, for those of us who have to do this. Just make sure that the wire you do for your bifurcation and provisional stenting, just to be aware of their properties. For me, I learned from Aaron the feeder wire, so it's works for me, and I usually can pull it out.
Yeah, feeder wire has been well described, that easy to remove and doesn't damage anything. But the problem with the feeder wire is that there's a risk of inherently of a distal perforation because it's hydrophilic. So that's why I don't prefer to use it, and I usually use the Sion Blue, and no issues removing it from trap stand underneath the trap stands.
Thanks, Prof. So your ectopics have come back, huh?
Yeah, I think so. It's intrinsic. It's nothing to do with our wires, I think. So currently now using a 3.5 NC balloon to try to tack up the proximal LAD and into the left main.
20.
Yeah. Can go to 24.
24.
Yeah. We're at 24 now, so it looks still a little bit constrained, but I think the vessel is size big enough. We go to the edge.
So based on IVUS, how big is the vessel and how big do you plan to go?
The left main is about 5, maybe a bit more. LAD actually is more than 4. So I think 3.5 is a reasonable number. We'll see the IVUS how the expansion is. If the lumen is adequate, I don't think we need to go to 4. There's always a risk of perforation. And IVUS sizing is a bit bigger than the OCT sizing, right? So we may be
Or 5.
oversizing it.
5. 12.
So what we could do is that if we use the EM-based way on IVUS, we downsize it by 0.25. So if, for example, the IVUS shows that you go to 4, then you can use a 3.5 or 3.75 NC balloon.
Yeah.
In your practice, Hui Wen, would you prefer to use, to what degree would you rely on the IVUS for a lesion like this, especially with the deal with low contrast?
Yeah.
Is it good enough for IVUS that you don't have to take a picture? I personally get very anxious without angio, but I don't know. What do you think?
Thanks for the question. I think we are always, it's a reflex and that we like to inject contrast every time we do something. But in this case where the patient has CKD, I think IVUS is good enough for us to guide our PCI. If the patient has no symptoms, there's no ECG changes, I don't see there's any reason for us to do any contrast injection in this case.
Okay, thanks very much. Yeah, I think it's one reason why we showcase the low contrast, the CKD case, just to illustrate the different techniques and that we can, with confidence, use IVUS to help guide the procedure.
One of the tips when you cannulate the left main without contrast is to either pass your guide wire down and then it goes down, then of course you're sure you're in the left main. But if you haven't got a guide wire, what you can do is inject saline, and you can see some ECG changes which will help you ensure that your guider actually is in the left main. That's one of the tips that they have advised on.
When you have a comment?
I just want to ask, because just now we talk about guide extension for contrast injection. What about microcatheter to inject contrast? Then you just use 1 or 2 mils. But you have to probably use a bigger size guide.
Yeah, so the question is, instead of using guide extension catheter, can we use a microcatheter to help with contrast visualization, and that will reduce the amount? Alan, any experience or?
No, I think for really low dose contrast, usually I almost never inject contrast until at the end. Because as I mentioned, some of the panelists, it depends on the patient's symptoms, EKG changes, hemodynamic compromise, and I always depends on IVUS. If IVUS is clear, nothing goes wrong, there's no edge issues, and the stents going up and then. Most difficult part is whether the side branch, especially in this case. I think leaving the circumflex side branch here has served two purposes. First of all, it's facilitated for you to rewire if anything goes wrong. Secondly, you're able to position your pop balloon to the best position. Don't go too far to the LED. So this circumflex wire will serve this purpose for you to enable to have a best pop position. So usually at the end, I will only get the final, so-called the final legal shot.
Ronald, any experience with the small microcatheter for visualization with contrast?
Yeah. Okay.
I think
but not always.
I don't usually do that. I think it's hard to inject enough to visualize, so not serve. But I think sometimes if no choice, it might be an option.
I think the microcatheter shows whether the distal vessel is still patent, right? At the end of the day, if you don't have edge issues and then EKG is no change, then I think there's no doubt. And most of the time, tip injection in the big vessel, the quality will not be good. Unlike, for example, a channel injection, tip injection, then you just need to repeat it, puff a few cc, and then you don't get a good image.
Yep.
So it didn't give you much information at the end.
So, Prof. Koh, where are you now with the?
Okay, so we have post-dilated the left main port already. So we are going to IVUS it and see what is it like.
Prof, what's the size of the balloon that you used to port?
4.5.
4.5.
Yeah, we went up to what, 18, is it? Or 20?
18.
Yeah.
4.5, 18 makes me nervous.
No, generally I will go up to 24, you know.
Okay.
Because your IVUS is 5, more than 5, so I don't think there's a major issue. And there's no major lesions in the left main.
It's just one comment. From the last IVUS, there's some uncertainty over the distal stent edge. Probably we can focus a little bit on that.
No, it looked very good, no? We can show you. Yeah. This is the distal beyond the stent.
It seems there's some edge dissection. From 8 o'clock to 12. You can maybe.
You think so? I thought it's just a plug at the bottom end.
It looks like there's some issue there.
We can analyze again after the pullback.
Yeah, okay. There is some plug beyond the...
Yes.
Yeah, all over. See, so we just wanted to stand where, you know, there is a least plug.
Just have a question. When there's a suspicion of edge dissection, would you then consider injecting contrast to confirm?
That degree may not be able to pick up by traditional angiogram.
Yeah, the question is Aisha asked us if indeed there was edge dissection, do we need contrast to be sure? And I think I would say that it depends on how obvious it is. If it's very obvious, then maybe I wouldn't. But then again, if it's small, your contrast may not show. So it's one of those depends. Yeah.
There's some criteria about whether you need to do any further work on edge dissections as well, right? Yeah.
So on IVUS, if it extends, it involves the media, then I think more likely you need to be intervened. Yeah. Right. And if the quadrant is wider, right? More than 60 degrees at least.
I think if it involves more than 2 quadrant and the length of the dissection, but I think the angiographic classification of dissection, it was developed in the pre-stent era, but still very useful to assess if there's persistence of dye with slow flow. I think you have to do a bailout stenting. But
are you interrogating the distal now?
We are manually looking at the distal. It looks like plaque, but we may.
It's just, it looks to me, it's just like plaque. There don't seem to be any flap there. Yeah.
What do you think, Alan? Are you convinced?
Right. Definitely, there's the stent was landing in plaque, but 8 to 9 o'clock suspicious, but it's not full limiting. I think it's not.
What about the rest of you?
On the 9, because IFS, the resolution is always less than the OCT. But
the stent could have landed in the area that has some plaque, but
Jianming,
but that I don't think it look very significant.
Can we pull back the left hand?
Just wondering if you can see the iris again.
One moment.
We're just going to do a manual pullback on the left main side.
Left main looks very well expanded here, actually. Yeah, even with 4-5.
Can you go to the ostium of the sub?
Going to manually pull back to the ostium of the sub. Let's go live. Manual. Let's record. The sub wire is coming in from the top there. You can see at 12 to 2 o'clock. At least for this off-angle view, the lumen looks pretty decent.
It looks quite good. What do you guys think?
I think it can be left alone.
Yeah.
Good to me.
The folks here think that it can be left alone. Idu has a comment.
Actually, I was thinking that there is some very proximal circumflex lesion, and you still need to do a kissing maybe before you're done.
Actually, the ostium of the circ doesn't have any disease. It's the proximal, actually proximal or mid-cert after the first OM that has some disease, moderate. I was it earlier, so we don't intend to dilate that one. So I think we are quite happy just to do this. So maybe because I think otherwise we would DCB the proximal LAD, the in-stent restenosis. But I think we are almost out of time, right?
Yeah.
So maybe we will do an injection to show you what the vessel is like without removing the wires.
I will take out the circ wires to get better.
No. Leave it there first. Yeah. Can we got a thrombustor? Yeah. So we'll show you one way to reduce the contrast by using a thrombustor to inject dye.
And your 7 French will facilitate that, of course.
Yeah, actually you can use 6 French as well.
6 tight.
Yeah, but it can be used. So that one really can save you a lot of contrast because you can put it into the where you want to inject. Sister.
So, Prof, with that picture, I think we'll come soon to the end of the transmission. But we really want to see the pictures. But while waiting for the catheter to go in, I must say this is a really elegant demonstration of complex PCI. With how much now you've only used 5 cc's of contrast. You got to at least make it a double digit, but it looks tremendously amazing. Let's see the angio results.
So the advantage of this one is that it's a monorail, right? So we can bring the catheter all the way in without a problem. Okay, enough. I'm going to take this one.
This is the Thrombustor 2, is it, Prof?
Sister? I've not been doing calls for live for primary PCI, so I'm not sure the name. Okay, so we will do a cine for you here. Okay. So I think I just injected maybe about 2 cc's of contrast.
Yeah, the folks are clapping here, Prof.
Yeah. So I think we probably, come to the end. We need to DCB the in-stent restenosis with the 3-5 sequence, please. And then hopefully we can remove the circ wire and see how everything is. There don't seem to be any dissection in the distal edge. Yeah.
Prof, thanks very much
thank you.
for a wonderful demonstration. Can I just trouble you, just a quick roundup summary of the key points, and then we can let you complete the rest of the case.
Okay, thank you very much. So we here showed you how we can do a minimal contrast PCI for patients who have CKD. In this patient, he had a recent angio PCI, and there was a bit of a creatinine rise. Fortunately, it came down a bit. This is a very complex case. Fortunately, we have some markers that we can use, like stent boost, metal wiring, and also IVUS, which is extremely helpful. And of course, the reduced amount of contrast use things like thrombustor. If you have, of course, cost increase, but in terms of patient safety, is better. And I think that the fine cross catheters doesn't image adequately. I've tried that; it doesn't work. So I think we are quite happy with the result. I'd like to thank all of you for staying till the end of Sing Live 2024, and I leave KK to close the Sing Live for me.